Good evening, everyone. Not every ICU story ends with recovery, but every patient deserves dignity, comfort, and respect in their final journey. As intensivists, we are trained to save lives, to fight, to intervene, to push boundaries. But there comes a moment when the question shifts from can we do more to should we do more? End of life care is not about giving up, it's about choosing the right care at the right time for the right reason. In India, this becomes even more complex where medicine meets law, culture meets ethics, and family becomes central to decision making. Today, we are here not to just discuss protocols, but to reflect on humanity, compassion, and responsibility. Let me introduce to my esteemed panelists for this talk or for this panel discussion. So, I have with me Professor R.K. Mani. Sir is affiliated to Yashoda Hospital. He is Director Clinical Services, Chairman Critical Care and Pulmonology. He's been past President of ICCM, past editor of IJCCM. We all know his area of interest are end of life care guidelines. He's been part of simplification of Supreme Court legal procedures for withdrawal and withholding. He's been part of the Ministry of Health Affairs guidelines for ICU admission and discharge on withdrawal and withholding life support in ICU. Then we have Professor Shivakumar Iyer. Sir is Deputy Medical Director and Clinical Governance at Bharat G Hospital, that is deemed University Pune. He's been an adjunct assistant professor, Prince of Wales Hospital, Hong Kong. He's been past president of ICCM, member of End of Life Care uh, Committee of the Bharat G Hospital, and his area of expertise are neurocritical care, end of life care, ethics, communication, and education. Then we have Dr. Roop Gursahani. We all know Sir is highly regarded consultant neurologist and epileptologist based in Mumbai in India with over 30 years of experience. He currently serves as the section head of neurology at the PD Hinduja Hospital. Beyond clinical practice, he is a prominent advocate of neuropalliative care and end of life care in India, frequently writing and speaking on death literacy and the importance of advanced medical directors. He is Director Forum of Indian Neurology Education and founding member of International Neuropalliative Care Society. He's been a section head and consultant neurologist at PD Hinduja Hospital, former member of National Task Force on End of Life Care, and course director of International Neuropalliative Care Certificate course. We have Dr. Kalavathy with us. She's been a friend, senior consultant of critical care, SIMS Hospital, Chennai. She's secretary of ICCM Chennai and president IPAN India Chennai chapter and founder secretary of MediAssist. She's been awarded with Tampa and Limbra Award for Excellence in Medicine and also the Presidential Citation Award by ICCM in 2026. We have Dr. Parveen Kaur, is leading Indian intensivist specialized in oncocritical care, currently serves as the consultant and head of the medical intensive care unit, Rajiv Gandhi Hospital, New Delhi, founder and president, co-founded Oncocritical Care Society to promote specialized education research for managing critically ill cancer patients. So let's start with it. Let's begin with the most fundamental question, how we define the end itself. And Gursani sir, what defines a good health within the Indian socio-cultural context? Is there a conflict between cultural expectation versus ethical principles?
So, good death has always been argued about, and there were lots of things that have been looked at. Three elements that I personally feel are important, and as you go through the literature, there is another one that comes up. I look on the first as communication, so that the patient knows what's coming up, can prepare for the end, uh, complete a life review, complete whatever the expectations are. The second is that the patient should have control over who is present, where death occurs, and so on. And the third is comfort. So three C's. So last, comfort is actually paramount. I mean, there should be, uh, you know, uh, not just comfort as in terms of control of pain and distress, but also spiritual caring, psychosocial support, and all that goes with it. But the thing is that what you said, Bharat, is quite correct, and that is cultural expectations in India are not focused on individual autonomy. Our autonomy is a little different. One term that has been used is swadharma, and the other way of looking at it is in terms of relational autonomy. So we do exercise our autonomy, but in the presence of the networks that surround us and support us. But at the same time, I think as doctors, all of us have the responsibility of upholding individual autonomy. And just because the patient is silent doesn't mean that you let the loudest voice take over.
So before we go deeper, it's important to anchor ourselves in ethical foundations. So questions are to Kalavathy for what are the four pillars we talk of: autonomy, beneficence, non-maleficence, justice, and how do they apply in the ICU?
Yeah, as you said, these are the four pillars on which our whole practice of medicine stands. And so when it comes to autonomy in the ICU, most of the time it is their basic right, but in the ICU, it is most often the surrogate decision makers who are there. And our patients, particularly in the ICU, are unconscious or not in a position to make a diagnosis and sorry, to make decisions. Um, so the autonomy here is indirect, and we need to know the primary stakeholders in this. Many times in the Indian scenario, the neighbors or the second line of relatives, they also come and pitch in, and they will be the ones who do the talking. So we need to make it very clear. We need to be very clear that uh, whom are we addressing and who is the one who is making decision, because we have had patients come being accompanied by benefactors. There is once an employer came and he said that we are a family, and then on probing they backtracked a bit and said we are like a family, and we are interested in them, and we are the ones who are sponsoring and making decisions. So none of those things would do. So if the patient is conscious, yes, autonomy by the patient himself or herself, and or at least we need to know the surrogate decision makers. And generally in our scenario, it is a family centered decision making, and it is a cultural thing also for us. And living wills and advanced directives, uh, like they are yet to get more popular. We need to make sure that the procedures, the decisions on ventilation and tracheostomy, all these things are communicated well and clearly with the pros and cons, and informed consent is there. So all these are um, uh, what is it? Our practice of autonomy as regards the patient's decision making. Sometimes the family say, doctor, you do whatever is best, or sometimes it is thrown on us, if it is your father, if it is your mother, or if it is your um, whoever, you decide. But again, I think we need to be very careful, gentle, and at the same time help them to make a decision, and not compromise on the autonomy. Then comes the pillar of beneficence, where what is beneficial for the patient, and not just the complaint that they have come with, but in a wholesome sense. So before initiating life-saving therapies, we need to take a uh, um, comprehensive look at the whole scenario, and then make decisions or help them make decisions regarding ventilation initiation, vasopressors initiation, and when it is sepsis, are we doing justice by early antibiotic initiation? And wherever recovery is possible, are we doing aggressive resuscitation? So uh, beneficence, I do the best that I am capable of for the patient. Here we also have the
Third pillar, non-maleficence.
various zones of families' expectations, and then fear of litigation and emotional factors. These can influence our decisions, but what we need to remember is that beneficence is not a maximum treatment is not equivalent to beneficence. We need to take the patient scenario as a whole. And non-maleficence, again, it's a non-negotiable pillar. We do no harm, period. So avoiding causing any unnecessary harm or suffering or uh, like when we are able to assess the patient and when we connect with the family and explain to them in case it is medically futile, then we need to explain to them that it is medically futile and any aggressive therapy is going to be more harmful. uh, the aspect of technological harm, there is a technological development, many things are there available in our armamentarium, but is everything beneficial for the patient? We may not, we should not end up doing more harm to them. And justice, again, the resources in the ICU are limited, the personnel are limited, the human resource is limited, technological resource is limited, financial resource is limited. With all these limitations, we address this issue of justice. Uh, so this is again a strong ethic, and uh, there again comes the issue of finances also. But I think a sense of justice needs to prevail and help us in our decision making. So there is always going to be a tug of war when we are making decisions, but they need to be along with the family. They need to be informed decisions, and whenever the patient is conscious and able to relate and able to make decisions, they need to be directly involved, and we need to know the surrogate decision makers and the stakeholders in the relationship.
Yeah, very nicely explained all the four pillars. We'll move ahead. Dr. Praveen, we all spoke about the four pillars. We now know what the good death is. But in reality, what we practice may differ from what we preach. And in India, is patient autonomy generally respected, or do family driven decisions predominantly shape care? And if at all, then who assumes the role of or who becomes a surrogate decision maker in our setting? Dr. Praveen.
See, as Sir has already mentioned, that our autonomy is slightly different. So, in our culture, especially Indian culture, there are a lot of family members who eventually will, become a part of decision making. Whatever we may say, yes. But in as I work in a cancer setup, so sometimes patients know about the diagnosis. They know about that the expected life is somewhere, whatever has been told to them by the oncologist.
This is
So
what is
sometimes
important. You said
patients
sometimes
are
patient is aware about the diagnosis. So isn't it wrong why sometimes patient is aware about the diagnosis? Why not always?
because no, it is not, and it is practically we are seeing, and we tell them that see, you are coming to a cancer hospital only, and it is written. Still, they will request, please do not discuss in front of the patient, do not disclose. So, as a respect to family, we just don't speak to the patient directly about his diagnosis. So what I'm saying, if patient is aware of the diagnosis and his life expectancy, sometimes they are clear to what extent they want to go. But most of the time, it is the family who's taking the decisions on patient's behalf. So yes, it on paper it seems yes, autonomy is important, and it is important if we are able to practice it. But eventually, lot of family members, and especially as Dr. Kalavathy was also mentioning, that once the patient becomes critical and comes to ICU, lot of distant relatives will suddenly appear, and they start taking decisions, start making decisions. So, but that at that time, I think intensivist and the treating team has to be very clear to whom they are speaking. So we have to always, when we are talking to our patients' relatives or attendants, we have to specifically ask them how they are related to the patient, how close, and then we have to ask their family members also. So I think eventually, but in the long term, maybe this coming with advanced directives and living wills, probably be everybody will be in a powerful position to decide for themselves. But as of now, it has to be, a family decision most of the time.
Yes, sir. You want to say something, Dr.
Yeah,
Gupta?
so quick issue here is that we don't have a surrogate hierarchy that is put down by law. Most
Yeah.
Western countries that is already
Yeah.
done. In India, the only one that is available is the end of life care guidelines of All India Institute of Medical Sciences. Since that's a public institution, I suggest we look at that and follow that. It's a little interesting to note, which Indian families often don't like, that the spouse comes above parents. So sometimes you may have to
Yes.
say, "आपकी इनकी बीवी कहाँ
Yeah.
है?" You have to keep that in
Yes.
So
Yeah.
this brings us to the real ICU, common ICU dilemmas and doing more versus doing right, sir. So Manish sir, this for you. As he said, there are few patients who are not even aware of the disease they are going through, the treatment what they are going to go through. So in the Indian ICU, can benefits and override the patient autonomy is doing everything always ethically justified?
You see, it's not that one overrides the other. I think one has to balance all the four pillars. That's how I look at it. You may put it as a tug of war between two principles, but usually we have to reconcile them rather than one scoring over the other. Because even if autonomy is respected, you have your duties of care, of beneficence and non-maleficence. You It's not a menu card you present to the family and say whether you want it or not. You have to empower autonomy. You got to empower their decision making by truth telling, by exploring the facts with them, by going through the acceptance and facing of the fact. All this is part of your beneficence. Beneficence also includes empowering the patient or family to see things clearly and take an independent decision. I do agree in Indian scenario, autonomy is actually family autonomy, but I don't subscribe to the view that you don't try and glean the patient autonomy. Even in the oncology setup, you have to talk to the family why they want it concealed from the patient and negotiate somewhere where you can apprise the patient of facts, because that is the law. You have to relate to the law in that way, because your primary responsibility is towards the patient. So I think what we must do is not to override one over the other, but try and negotiate. Okay, try and negotiate a proper mix of beneficence and autonomy. That's what all our guidelines tell you. Even the Supreme Court advises a cogitation with the family. That's what it means. And our ISCCM, IAPC guidelines also say the same thing. You have a shared decision making. Sometimes one or the other slightly predominates. Okay, the autonomy may predominate in one, or beneficence may predominate, where the family wants your guidance predominantly, because you can't force autonomy on anyone. Their families or patients don't want that pure autonomy where they have the final complete say. They always want your guidance. So that we must understand. This is not a mathematical formula. It is a proper consensus, and we must have the patience and the clarity to drive that consensus. To my mind, in my practice, the hierarchy is not found to be important to me. Okay? Because I take that all the important family members must have a say. I listen to them. Of course, it is not only in the All India Institute document, it is also there in our transplant document at DOA.
Oh,
There is some kind of a
no.
hierarchy. I mean, it's there. I mean, it's not there legally, but it's there by consensus. So there, the spouse comes first. So I do take it as important, to get the spouse's view, and I try to keep to that hierarchy that's mentioned in the Toa. The issue is, but in practice, I take these decisions every day, at least two or three every day, and it is not such a deterrent as it is made out to be. Okay, very few people land up in courts and to argue the hierarchical situation. That sort of thing is rare. What I would say is, therefore, it's not beneficence over autonomy. It is not individual over family autonomy. It is a consensus between all the important people important to the patient. And then people differ. There are people who are very assertive also. They're assertive of their autonomy. So you have to individualize. It's not a one glove that fits all. But what one should drive is proper negotiation, a sincere attempt at marrying diverse views within the family, marrying diverse views within our physician teams also.
Yes.
So that is the skill, and that skill develops. It is not so daunting. It's as it appears initially. As we practice every day, it becomes easier and easier. Like any other procedure
Okay.
in medicine, it gets easier to put a central line as we
It
keep
gets better. Yeah.
doing. It takes easier to intubate in a difficult intubation as we get better at it. So here the skills are different. They are soft skills. They are skills of patience, skills of negotiation, navigation, the skills of communication. So all this can be improved and trained, of course. But this is where it is. We want to marry the four principles in every case. It's not just autonomy. I think that's overemphasized. Even the Beauchamp and Childress book on biomedical ethics says that they are equally important. And that's what we must remember in our practice.
Very, very precisely said, sir. It's not one over the other. We have to balance all the four pillars, and this is what we always look into. So even the yes, sir. So even the language, as you all spoke, reflects how we think about end of life care. So why we should prefer withdrawing life support over passive euthanasia? Is the term passive euthanasia, absolute in clinical practice?
So the question is that what is the more scientific term and what is accepted worldwide? So clearly, withdrawing life support um, describes the practice of uh, withholding or withdrawing life-sustaining treatments appropriately. Passive euthanasia, on the other hand, is an oxymoron because euthanasia means actively supporting the dying process. And so saying passive active support of the dying process doesn't make any sense. And so therefore, the term is not obsolete because, I mean, even in the recent Supreme Court judgment, you could see that the term passive euthanasia was again
It's
used.
autonomy.
And an unfortunate thing is that that language continues to be used despite uh, efforts by all of us working in this field of end of life care. The ICMR document on definitions related to limiting life sustaining therapy. So all these documents are there, and yet the term passive euthanasia refuses to go away.
Gursahani sir, you want to comment?
Yeah, so I think one thing that we all need to remind people is the history of the word euthanasia. It first started to appear towards the end of the First World War in Germany. It became ingrained in public speech in Germany as the Nazis took over. And then the Nazis used the term euthanasia to justify the Holocaust because they started it by first killing something like about 240,000 neurology and psychiatry patients. Yes, those numbers are forgotten, but the gas chambers were first used for patients. So that is where the word euthanasia began. It has a horrible history. And I mean, the word itself should be euthanized.
Yes.
Yeah,
Good one.
true.
Kalavathy, you want to say something?
Yeah. Actually, the word passive euthanasia has got a very negative connotation, and it can erode trust among public also. I think it should, as sir said, it should just go. Because when a patient comes to the hospital, they need to be very confident and have trust that what is good for them will be done. These words don't go well. The word passive euthanasia.
So let's move on to the clinical decision making and real world principles, what we are looking into. So, Dr. Parveen, you must be coming across quite often working in the onco critical care unit. So, what defines medical futility in ICU practice? When should futility be declared and by whom? it should be done? Should there be a unilateral physician decision in extreme futility? Parveen?
So medical futility per se, I think it should be rather what is potentially inappropriate treatment for the patient rather than futile. And declared when we see the prognosis, we know intensivists, the treating units, all the concerned specialities, when they see that the disease has reached a stage that nothing much can be done so that patient's life, which can help in a good quality of life. So it has to be decided, and it cannot be just it is not to be declared. It's a slow process. You have to discuss with the family, you have to discuss with the attendants, you have to discuss with the treating team, and it has to be, it's a gradual process. You keep on discussing with them. And of course, it cannot be just unilateral physician. That is not true for any decision for that matter in our medical this thing. It has to be combined decision. Gradually, they have to be told about the disease, the prognosis, what we are looking at, what quality of life we are looking at. And it takes, lot of, as sir has already mentioned, Dr. Mani was also mentioning this, lot of communication is required, lot of patience is required, empathy is required. You listen to their concerns, and eventually you reach to this thing that now further potentially it will not be of much help to the patient. So it has to be a combined decision, definitely.
Yeah.
You
Thank you.
know,
And even in when we talk about advanced metastatic disease, it's been like I think 6 years now, and it's just a cancer center. But you see, advanced metastatic disease also people will still ask you, please सब कुछ करो, सब करना चाहते हैं हम, आपको क्या problem है? We have the money. You see, but then it cannot be, then when we know that it is not of any help, then it has to be a gradual process. Keep on talking to them. And more you talk to them, I think then rapport forms, and then they start, trusting you. Because as intensivists, we come in picture when there is eventually that stage comes. And the primary team is with them till when they start coming to, OPDs and repeated counseling. So definitely they have to be a very important part in decision making.
Gursahani, sir?
In neurology, it's often something that is obvious at the moment you see the first CT scan. And you cannot, you have to let the family know that this individual will never be normal again. You have to uh, give the warning shot. And what I prefer to do, and I think this is something that is coming up again and again in your literature, is a plan for a time-limited trial, at which is usually 2 to 3 days, max about 5 days, and that allows you to shift the negotiating boundaries.
see, Bharat,
Yes, sir.
I want to say that the futility being replaced by potentially inappropriate, but then there are situations where it is truly, futile. Okay, that we see in the ICU all the time. Futility is one extreme end of a spectrum because you have a spectrum of scenarios. Okay, most of them are in the gray zone. Okay, particularly if you see a demented patient in the OPD, that's different from an extremist patient in the ICU. Okay, both are not in the same category. Most of the people are in the gray zone when you're not sure. Then, if you're truly in the gray zone, then a time limited trial applies. But if you're truly futile, okay, and physiologically futile, which does happen in the ICU, then there is no point in going through a TLT.
Yes.
And similarly, in oncology, if there is advanced, refractory malignancy, gone through many cycles, then you can use the word futile. And because it drives the point home, we don't have to sort of hedge around the word and calling it inappropriate, because inappropriateness is a more gray, more
it's a little vague.
negotiated understanding. And it takes time. So it depends on the individual situation. A situation where it is clearly futile in the ER, when you can tell the family it is futile to resuscitate. So that is where our skill comes. It's a clinical judgment which you should be able to convey to the family. Now, when the family is not prepared by the primary team of oncology or neurology, they've never had a conversation, a serious illness conversation. They've never had their turning up in critical illness. So that is a problem. But then we should give them a chance to have a serious illness conversation as soon as within first 48 hours, when you're seeing that scenario, so that they are prepared. Because what is your problem? We have the money, that is a very superficial opening lines. As you delve deeper, you apprise them of reality, you talk to them of suffering, not talk just about diagnosis and treatment. You talk about suffering and what is appropriate. That is a skill we must acquire.
Got it. Shiva, yes, sir, you want to come?
Yes. So, the last question that you said, should there be unilateral physician decisions in extreme futility? So, when we say extreme futility, it could refer to something like a do not resuscitate.
Right.
And this practice of do not resuscitate being a medical decision has been reinforced by the ICMR paper on CPR, which Dr. Mani had co-authored. So I think that is one example where you're informing the family that you won't be doing CPR. You're letting them know. You're not asking for them not to do CPR. That's one area. Another place is what happens is some families are not able to decide about withholding or withdrawing therapy, though they know that it is the right decision, and you're not able to get the documentation done. And this is where we are on an ethical boundary. You don't know whether it's right or wrong. So the term sometimes used for not continuing such therapy is described as slow code, or sometimes it may be described as something called informed non-dissent. So you've informed the family agrees that there is futility here, but somehow they are not able to decide or able to put their decision down on paper. So in such cases, maybe there is a case for, and I know what I'm saying is controversial, maybe there is a case for such unilateral decisions.
You see, I agree, because resuscitation CPR is a medical treatment, and the decision is based on indication. Okay, it's a physician decision. So there are cases where it's very clear-cut futility. You can take a unilateral decision. Okay, if it is not in the interest of the patient, clearly. Those situations do arise.
Agreed, sir. Parveen, you want to say something? You raised your hand.
Yeah, I was just because just now, 2 days back, we had one patient who's cardiac amyloidosis, renal amyloidosis, and of course, he has been counseled multiple times by us, by everyone around. But eventually, as sir was mentioning, sometimes it happens, daughters were like, we know that probably nothing much could be done, but still they went ahead with, ventilation. So that is what I was that this unilateral physician decisions, how is it really possible for us? Because we also knew, they also knew, but then the daughter said, no, we want to go ahead with it and we have to do it.
So this is what
So,
this question is to the Kalavathy about the conflict situations where things get more challenging. So how should clinicians proceed when consensus cannot be reached between the family and the treating team? And what is the appropriate course of action when family insists on full support despite being the medical futility? This was the Parveen brought it out. Kalavathy?
Yeah. So first and foremost here, I feel we should establish trust. The family should come to trust that my treating physician is for me, and I can entrust my precious one with this physician. That is the underlying ethos that has to be established, and there is no negotiation about that. And we need to make it clear that we are all on the same side. We all want the same thing for the patient, the benefit of the patient. And it is just that they are bringing something to the table, and we are bringing our expertise to the table, the scientific information, all that. And communication has to be an ongoing thing. It is just not once a day. Sometimes suddenly somebody gets a brainwave, some sudden doubt, and they would like to talk. So we need to be available, because these are very weighty decisions that the families make, and they have to live with the decisions they make for the next 40, 50, 60 years, however long. Suppose the child is making a decision for the parent, they have to live with the decision for their whole life. And everybody would like to be comfortable about it, and know that they have done their best of their duty. All these are the ethos that are involved in the whole ecosystem of making decisions. And yes, we do, it is given that we will get into these kind of conflict situations, and ongoing communication, then offering them a time limited trial, and are again and again going back to what goals are we looking at, what is the end point that we are looking at, what is it that we want for the person, what is it that the patient himself or herself would want in that place. All these again and again, when we talk on a comfortable note, where they feel comfortable to go back and forth, then a lot of these things can be settled. It is not going to be just a 1 day decision or 2 day decision. It may be prolonged, or sometimes as long as their finances, like in a private system, as long as their finances hold also. So family meetings, and then again asking them to get whomever they trust, and sometimes even to get a second opinion. All these ease in these cases. And if they insist, some of them are adamant, and means for want of a word, I would say adamant, but it is just they insist. So we continue, and we can give them very clear or measurable goals, and limited time periods like 48 hours or 72 hours. We'll see whether they improve, and should we again restart NIV, or restart or intubate, or should we again restart vasopressors. All these can be discussed, and when they are comfortable, many times the patients come to an agreeable point. Definitely there is a minority where uh, till the end they don't accept, or they find it hard to come to terms, because some of them, it is all very complex. They cling on to the person. There is an emotional clinging on. Sometimes even elder children we have seen clinging on to the parent, because there would be a background family conflict, and this person would be the one person who is supporting them. So many things are there. So I can't say that I'm an expert. I say you do, it will not work. But an ongoing relationship, an ongoing communication, and underlying trust, basically, all these things will help, and it will change. The whole conflict situation will be changed into a bearable experience for the family.
So very nicely put it across. And we all uh, spoke of this, and what we realize it at the heart of all this lies communication. So, yes, sir, what are the key principles of effective end of life communication? Shiva, yes, sir.
So yeah, when we uh, do end of life care communication, I think it is about the climate and culture in the unit and hospital where you work, which is most important. So when patients come in to the hospital, an initial assessment of whether there are palliative needs and there is a chronic illness in the background is very important to identify. So the first communication, which is done by the residents and the junior doctors, is so very important in order to set the stage for being able to decide early on if there is inappropriateness or disproportionateness to the care. Of course, this does not apply so much to patients who come in acutely ill. But still, the culture of communication starts with the first person who communicates with them. And this includes the emergency department and our junior resident. And then, of course, you know, uh, let us say that now we need to plan. So when the consultant is going to come the next morning, before he speaks to the family, he must take the trouble to find out and to make a good clinical evaluation, decide about what treatment is required, what is not required, assess the palliative needs, find out who are the other consultants involved, whether any family doctor is involved or not, who are the main stakeholders in the family. So this is very important, even when the consultant does the first meeting with the family. So preparing for the discussion, I think, like Bharat has so nicely put, is the first step. And then, of course, you follow the principles that we generally use in using the spikes model. So have a good setting, don't speak in the corridor. Make sure that you establish a rapport with the family.
Yeah.
Set aside all possible disturbances, including things like the mobile phone. Before you start explaining things to the family, explore, find out what they know about the illness, what their perception is. And this is especially important if there is a chronic illness in the background.
Right.
Find out what your resident has communicated, what has been communicated in the emergency department, what the primary consultant or the physician has said. So these are all important things to set the background. Then once you've done that, the next step will be to explain things to the family in simple language, in a language they understand. And when you do this, you give small chunks of information. And with each small chunk of information, after you've given that information, you need to check again whether they've understood or not. So this describes the principle of what is called ask, tell, and ask. Then what we have is a situation where you are going to break bad news. Then judging the testing the waters with the help of an invitation or a warning shot is most important. And then when you break bad news, and this is, I think, where most of us as clinicians, intensivists fall short. We are just not able to break the bad news effectively. So if patient is dying, then we need to unambiguously use the term dying or death when we describe this. Similarly, we need to say that there is cancer here, as is described in the cancer literature. If you don't drop the penny, so to say, the message will not get across and you'll not be able to explain things effectively after that. So dropping the penny is most important. Now, all throughout this process, the next two things which you said about listening and acknowledging emotions, I think it requires the most skill to be able to listen and to be able to be quiet and settled within oneself, to be able to pick nuances in verbal and non-verbal communication that indicate that there is some emotion in the background. One must remember now that if there are emotions, then whatever you may be saying rationally or trying to explain just will not get across. Because families are just not in a position when they are emotional to understand any of this. And it goes without saying that when you do this, you have to be honest and gentle. And as you near the end of the conference or the discussion, one needs to be able to explore what the goals of care are and to look at what preferences there are. So this, if the clinician, the main consultant, is able to do when he does the second visit, that is most important. And then, of course, the next principle in end-of-life communication, after you've done this initial talk, is to decide within 48 to 72 hours to have a family meeting. And preparing for a family meeting is also most important.
Got this, sir.
I think I'll stop here.
Yeah. So we spoke about the communication, but also very important part of the communication is it's come to the chat box, and Gursahani said you answered it to the few of them, but to put it across to all the delegates, so they are being worried about how do we document whether it's DNA, it's futile or inappropriate to continue, and what are the rules for the medical legal cases? Gursahani, sir.
So for medical legal cases, there is no difference. I mean, you're treating them medically. The legal part of it is somebody else's responsibility. Just make sure that your documentation is complete. And what was the other question?
The other question is how to document, is it DNA or do we mention?
So I think better we start having some kind of standard formats that we use. It will be good if the ICCM can take up this job, but we've already had a fair amount of hard work done by the AIMS team as well as the Manipal. So we can actually take those forms. Uh, I think at some stage maybe ICCM should.
No, there are formats. There are in the appendix of the
Where are they?
ISCCM. In the appendix
Yeah,
of
but
the ISCCM IAPC, last
yeah, sorry, as part
position
of our
statement.
yeah. As
Position
part of
statement.
sorry, I forgot that.
We have got
I forgot that. I
formats.
forgot
Yeah,
that.
we got
We've
formats,
got it.
and then you got a format for DNAR in the ICMR document, and you
Yeah,
have Manipal documents. So in
yeah.
the Blue Maple. So we
So
have got
the
formats already, and you can make your own format. For my hospital, I have made my own format,
Own form.
which I have
yeah.
shared with others also. Yeah.
So the best thing is for
Mm.
you to work on your hospital administration to have an SOP in place
Mm.
and to have these documents printed on your hospital letterhead. So there's no issue.
Shiva, yes, sir?
Yes. So a quick comment,
Yes, sir.
and yet, despite these formats having been there, the Blue Maple
Mm.
and the
Aim.
this
Manipal.
AIMS thing has been there for donkeys years now, and yet similar questions are being asked. So I think an important study is being done by the um, ICMR. It's an ICMR funded study, and KMC Manipal is the Center for Advanced Research on this. And what they're doing is they are designing a multifaceted, comprehensive, appropriate care package for ICU palliative care. And in this process, what is hoped is a broad consensus will be established, and there will be a website at the end of it which provides this guidance to all people. And through the process of this study, there will be a Delphi process, and there will be we have tended to publish guidelines and tended to write position papers without any real Indian evidence on the. So this study, I think, hopes to do that, and hopefully doing this through the process of this study, and then of course the website and ICMR, uh, and of course with the Supreme Court support, I think in a few years' time, maybe we should move towards uh, being able to better answer and better do this.
So, Manisha, there's one question in the chat where it's
Yeah.
written in a government hospital setup when futility of care is clear and where resources are limited, but health system pays, but the relative insists on continuing. And same is another question put up by Dr. Sonali Vadi. Is the same kind of situation. Your
Yeah.
patient belongs to certain corporate, money is being paid by the corporate. Though you explain the futility, but relative would want to continue. So, how do we deal those situations when it comes to the talking about balance, autonomy, beneficence, and justice?
So you see, there isn't a clear black and white answer here. I think what we do majorly, what I find many people when they communicate, they are only emphasizing the legality or the finances. One must emphasize the suffering aspect.
Yeah.
Our unfortunately our orientation and communication of ethics isn't with conviction. I mean, they hedge over those issues. They are only talking about the finances and law. See, when in the context of suffering, it doesn't matter whether you're paying a big bill or you're not paying a bill. Of course, paying a big bill is also a huge burden to the family, and that has to be taken into consideration. But you don't center the decisions on the ability to pay. You center it on the suffering and whether it's an avoidable burden or not. That's what appropriateness, that word carries. So in my own communication, that's what I've learned to do. I steer clear of finances, although I listen to their financial worries, but I peg my communication on the suffering of the patient and how that can be reduced, how it is pointless, and then even well-heeled people follow this line of thinking. It doesn't matter in what setting you are. In the Delhi setting and in the Mathura setting, second tier of city, there also I employed the same principles. To be honest, I didn't vary my communication, although the language varied. The principles didn't vary. Principles were pegged on the patient interest. If you if you make the best interest argument, okay, not a legal based argument, best interest argument that does appeal to a diverse uh, people different settings. So I would advise you, I would suggest to you that you go back and see, observe how you're communicating and whether that can be worked on. We need to work on our communication, basically. The whole intervention is about the quality of communication that you're able to bring to your practice.
Very rightly said. Kalavathy, you want to say something before I move ahead to next
Yeah,
one?
as Sir said, it should not be a fear-based
Communication.
fear-based offering of options to the family. It should be more of establishing a rapport, building trust, and then otherwise, even the patients and their families, they can make out when we are being defensive and when we are offering them defense-based solutions. So I think this is one of the key issues or key. I don't know whether to call it a skill, but a sympathetic approach or a compassionate approach. Many things fall into place when that is there.
I agree.
So, as we all went through, perhaps many of these conflicts arise, we all understand because maybe the conversation happens too late. So, should goals of care discussion be initiated early? And sir, since you're the founder member of neuropalliative care, and I know you started a department in the Hinduja itself, so if you could brief us, how can palliative care be effectively integrated in a routine ICU practice? As I listened to the story also other day from you, when the palliative care physician was in there, it was the ICU who asked for it.
Yeah. So the first question first, goals of care is something that we do in every clinical encounter, whether you're treating a sardi khansi or whether you're taking care of a patient who's dying in the ICU. And essentially, what you're doing is addressing three questions. One is longevity, the second is function, and the third is comfort. And in a sardi khansi, you can address all three. Nobody's going to die, I mean, unless they have something very weird. They'll be functional and comfort will be addressed. But towards the end of life, uh, longevity, function, and comfort often are uh, contrasting. And families and clinicians have to choose between maybe one or two. All three are usually not possible. And the way to handle it is to be aware of the values, the wishes, the preferences, the sense of duty that the patient and the family have. And this, unfortunately, is something that happens over a period of time between the patient and the family. It's not something that an intensivist can do in that urgent moment. And ideally, this is something that should have been sorted out with a primary physician. If that has not been done, then I think one of the things that you can look at is trying and getting a sense of what the functionality of the patient was before they came. Was this a fully functional, absolutely hale and hearty individual? Or was this somebody who was already frail, just about tottering around the house, needing help with basic activities of daily living? I mean, it's surprising how often families expect you to make them better than they were before they entered the ICU. Right?
Yes,
so you have to be
absolutely.
clear about that.
Mm.
Yeah, you have to be clear about that. So that's one. So goals of care, I don't think I would, as a primary, I mean, as a treating neurologist, I would not want. If this is a patient I know, I don't think I would leave it to the intensivist to sort out. It's something that I should have sorted out before they came into the ICU.
Absolutely.
The second, palliative care. Now, this is a little interesting. It depends on what your background is. If you're going to be a lone intensivist practicing, then you need to develop palliative care skills. And palliative care skills aren't very difficult to acquire. We differentiate between specialist palliative care, where, for instance, Shiva is a specialist in palliative care because he's actually got a qualification. But I provide primary palliative care or generalist palliative care. I do my own specialty, but I also have palliative care skills. And I think if you're a lone intensivist, then you at least need to acquire that. If you are in a hospital, I would strongly urge you to work on your managements to get palliative care physicians on the rolls and on salary, not honorary. If you look at a complicated situation, the palliative care physician is going to spend hours. And
To have
as
lost
Bharat told
voice.
you, can you hear me?
Yes, now we can hear.
Yeah. Yeah. So as Bharat pointed out, in Hinduja, we had a very effective palliative care physician who joined right in the beginning. Uh, and when he moved on to a better job, uh, I frankly, because I had put a lot of effort into getting him appointed, I said I kind of threw my hands up. And then suddenly I get a call from the CEO and saying the ICU team is here, and they are saying, when are you getting the next palliative care physician? Because the palliative care physician had proved his work. He had taken so much of the load off the ICU team that I keep repeatedly telling my intensivist friend, just do it first. But they have to be on salary. And I'm putting the figure out here. Nobody should be appointed for less than, at least in a metro city, for less than 3 to 4 lakhs. Right? There are enough people getting trained and coming out.
Yes. So this is very nicely put it across, and this solve the problems because there's someone who's been trained into look after, communicate precisely, and it will take off the load as we guys are more into the clinical thing, and overall, it as a team, it works in a better way. So as we move on, sir, Mani sir, this is for you. So India, we often see a unique workaround thing in difficult situations. So the llama is one of them. So why does llama still dominate? Are we using it to bypass ethical and legal processes?
Actually,
Absolutely.
it is a hope that you can shortcut all
Hope,
these ethical dilemmas and financial burdens and
hope for
and
doctors, no?
family.
Hope
Uh,
for
fa-
doctors?
sorry.
Yeah.
Hope for doctors.
Yeah.
Yeah,
Hope for
exactly.
doctors.
Hope for doctors that they know you want to you. It's a lazy way of approaching these large problems. Problems of talking to the family. Compassionately getting their trust, talking about the patient centricity. Ethics and suffering, unburdening the financial burden rationally by following good medicine. You pile on useless investigations and treatments and life support, which are only going to escalate the burdens, and you don't give the family any sense of how this can be mitigated. That it's a sense of frustration that makes them opt to go out with a terminally ill patient, without a plan. It's an unplanned, abrupt departure. To escape these burdens, the family also is confronted with very monumental burdens. So Lama is actually a failure. And now I'm very happy to note that in the Harish Rana judgment, the court has mentioned all that we are talking today, and we have been campaigning, against for a long time, that it is not the right thing to do. It's not a patient or a family centric activity, this Lama business. And it is rife. In the INDICAP study, it is 7.5% of all admissions are Lama, and 70% of all deaths are through Lama. So obviously, it's a grim scenario, and we must come out of this. We always feel that we are absolved of any legal liability if we send the patient Lama, which is very far from the truth. If the family is not satisfied, if you have if you have partnered company in this sort of a bitterness, then you can never be legally safe either. And that was clear by the Adya.
Yes.
There is a young girl whose case was there,
Beach
it's a
one.
10 crore suit, Adya Singh, yeah, where the patient was sent Lama and she suffered when she died on the ambulance, and then the family took the hospital to court. So let us do the right thing. The answer lies in doing the right thing. If we are able to take appropriate decisions of withdrawal and withholding in time and timely shift to palliative care, which is far less expensive than this technologically advanced care, and then relocate the patient if the patient wants to die at home, then facilitate that process. Have a planned discharge, have planned care at home, or to the ward in the hospital where it is less expensive. So all these options can be explored properly with the family. There is so much of defensive medicine. It is not patient-centric. The Lama is self-centric. So how can you justify a self-centric activity when you profess patient centricity? Okay, as quality, okay, ICU quality is measured in patient centricity and family satisfaction. This is what it is. The modern metrics are these. And how can you justify Lama anymore? In my own practice, I've consciously reduced Lama incidents, almost virtual zero in many places, but it is still lingers, sporadically because you don't have all your team members with you. They're in the hospital. There is a lot of conflict, and conflict management is not good enough. That culminates in Lama. Lama is always a failure of your ethical climate.
So,
Yes.
if I might just interrupt, I mean, if any intensivist who has palliative care skills will not do Lama,
Yes.
it will not happen. I know, for instance, Hinduja Hospital, the numbers we can count on one hand in a year.
Yes, absolutely. That's what has happened to us as well. Yeah.
Yeah.
So I'll move on to the next question, sir. This is an important one of the whole context, and anyone else can come in. This is addressed to you, Dr. Mani. So, how did the 241st Law Commission report differ from 196 in shaping end of life care policy? And also, what are the key insights from 2018 Common Cause judgment, and what changes were introduced in 2023 Supreme Court clarification? So, this is basically, if you could tell us the whole journey.
Yeah. I'll just tell you in brief.
Yes.
In 2006 was published the 196 report of the Indian Law Commission. That was path-breaking because the opening lines separated withdrawal withholding decisions from euthanasia. Okay, the opening line said this is not euthanasia. This has got nothing to do with suicide laws. Those days that's what bedeviled the concerns of the public as well as the physicians, that it can it be misconstrued as abetting suicide and all that. And in the 196 commission, it did not use the word passive euthanasia. Okay, very importantly, they used the word withholding and withdrawal. But the 241st report, it's titled Passive Euthanasia, a Relook. Okay, it was written, published after the Aruna Schonbock judgment. Okay? It was in the Aruna Schonbock judgment that they tortured the word euthanasia, passive euthanasia, voluntary passive euthanasia, involuntary passive euthanasia, and so on. Okay, and so the 241st report was just to accommodate the Aruna Schonbock judgment. Okay, and it put its procedure. See, in the 196 report, appealing to court was optional. Okay, it was not mandatory. What they had prescribed was a public appointment of experts and three experts in the panel to make the decision. Of course, that is also far removed from reality, but that's what they had mandated. However, the 241st report mandated court procedure, okay, high court procedure, because they conflated the whole of these decisions with the permanent vegetative state decision, okay, PVS. That was the referral point of Aruna Schonbock. So that was the way it was actually. It was a regression. It's more complicated than the 196 report. Rather than simplified, complicated it more. The 2018 judgment was truly a milestone on this path. Why? Because it expanded the scope not just to the PVS situation, but the entire gamut of withdrawal withholding decision, and pronounced very clearly that it is constitutionally valid to refuse treatment on the basis of the privacy and the on autonomy as enshrined as defined in the right to life in the Article 21. That is, right to life includes the right to die in dignity that they spelled out again after the Gyan Court judgment in 1994, 96. So they spelled out that you have the right to die in dignity and you have the right of autonomy and privacy. And if you are competent, then you can refuse any treatment. Any competent adult can refuse treatment, but this right of refusal extends to the incompetent patient through their next of kin or a legally appointed proxy, as with the AMD. For the first time, they validated the right to execute an advanced medical directive. Advanced medical directive in the 196 report was discouraged. Okay, by the first Law Commission report, they discouraged advanced medical directive, saying that it is liable to misuse. Our country is not ready for it. So that
No,
another
we are
part
all
breaking.
corrupt, doctors
Ah,
especially.
so yeah, we are all corrupt. Now, in fact, 2018
Except
also,
judges and lawyers, everybody's corrupt.
yeah, casts heavy suspicion on both professional caregivers, that is physicians, and family caregivers. It doesn't trust anybody, and that's why
Yeah.
it made three-layered safeguards. Okay, so we have to go through the district collector and the district magistrate of the first class in order to execute a withdrawal withholding decision. So what it gained in principle, it completely lost its way in the procedural
Reality.
detail. So this is what happened, and that's what culminated in the January 22, the later simplification appeal,
2023.
2023 judgment, which ISCCM, along with the Vidhi Center for
Vidhi.
Legal Policy, appealed. And that was a significant gain in the procedure. Okay, of course, it's still a little bit daunting, a little bit complicated,
No.
but it's far simpler and doable than the first one.
So
So
yeah,
I'm
please.
done, Bharat. Yeah.
Yeah. Gursahani, sir, you was saying something? I was just.
No. Go ahead. I don't know how much time we have.
No, I'll move faster now.
Yeah.
So we have three questions more. So what is this for you, yes, sir? So what is the stepwise approach to end of life decision making in the ICU? Because we now understand what the law is, but translating law into bedside practice is where the real challenge lies. And how do the two medical board function, including the composition? If you could explain in short.
So the answer to the first question is very simple. Just follow the ISCCM pathway, and it sets out all the steps very clearly in the decision making, starting with an honest appraisal by the treating physicians of the patient's condition and prognosis, and deciding whether there is futility present and the appropriateness or disproportionate of care. Once that is done, the next step is to establish consensus in the treating team. And once that is done, you talk to the family, take the first steps, and if the family is agreeable, along with that, go ahead and get the two medical boards to function. And this process simplification which is something which Dr. Mani alluded to, that the 2023 judgment did. So a primary medical board comprising three physicians, and now they require only 5 years of experience. So they make that decision, saying that this seems to be all right. There isn't any, and they concur with the decision. Then the secondary medical board is something which is again three physicians with more than 5 years of experience. And this part, there is a little complication where they say that one of the uh, persons in the secondary medical board needs to be nominated by the district medical officer. The Karnataka government has very neatly sidestepped this by saying that anybody who is on the brain death committee of a hospital which is recognized for transplant, that person may be nominated on the and there is a pending High Court judgment on how advance directives or living wills may, when the procedure of primary and secondary medical boards is so cumbersome, how can that happen? So this is Datar versus the state government. So I'm not aware if any progress has occurred in that. So that's how the two medical boards function. And once the two medical boards function, it is not incumbent on us. We have only to notify the um
Judicial
statutory
magistrate first
body,
class.
which has been, or the district magistrate of first class, we have to only notify. They don't have any role to play in the decision per se. And then we can go ahead with whatever process of withholding, withdrawing, or end of life care decision making that we've decided. So that's the pathway. I'm not touching upon the palliative care part and providing bereavement counseling. Those are steps which come afterwards.
So thank you, sir, for
Over to you, Bharat.
Yes. So as we progress, so we spoke about the advanced directives, which are a powerful concept, but I'm not sure whether easy to practice or I would put it across. Those are difficult to practice. So, Gursahani sir, this for you. So, how should clinician implement living wills? What if families disagree with a valid directive?
So one is, of course, we are right at the beginning of this whole business of advanced medical directives, advanced care planning. Hinduja has the first living will clinic in the country, and I was stunned by the kind of response that we got. In fact, the management was very surprised. It took me so much time to convince them, but it really, there is a huge desire for this. In practice, yes, if you have a directive that is clearly uh, valid, meaning it should not be like 10 years before or something like that. If it is in the past year, it takes into account current medical realities. It has a mention of the patient's diagnosis and so on. And it should have very clearly identified we call them the designated healthcare representative. So surrogate is default. Designated is designated. And if the designated healthcare representatives are listed, we are in fact looking at perhaps making it possible to do all of this through the Digital Health Authority. When the hospital gets it, then you are duty bound to at least take it on board. Whether you will follow it, it also depends on your own medical discretion. I mean, if somebody who has, say, a condition comes in with respiratory failure, and you know that 2 or 3 days later he'll be okay, then it is your duty to offer that care, even though the patient has said no. So these are things that have to be interpreted case by case. The second question, what happens when the family disagrees with the valid living? If the family is not the designated healthcare representative, then you have to first speak to the designated healthcare representative and ask them. Of course, you'll be speaking to the family also. If there is a conflict between the DHR and the family, then I would strongly suggest that you ask the DHR to approach the High Court immediately. That is if the DHR is willing to stand by all of this. Now, we are at the beginning of this whole process. Intensivists will be in the front line of this implementation. So it's good to be aware of how these things are changing. They will evolve. Cases will happen. As long as you are clear about what you're doing, there is no need to be afraid of anything. And if you at all require any help, Vidhi and the lawyer team at there, that they are there, are always willing to help in and guide us. So just understand that we cannot shrug our shoulders, throw up our hands and say, "Hum ye sab nahi kar sakte." It's not possible. We have to learn how to do this.
So, just to for Kalavathy, this for you. So implementation always bring us back to system readiness, as was spoken that Gursahani sir as well. So, and we all know about this 2023 judgment. So, are Indian hospitals adequately prepared to implement the 2023 EOLC guidelines? And should end of life care documentation we all spoke about be nationally standardized, similar to the DNR protocols?
Yeah, I would say we are partially ready for this through 2023 EOLC implementation, but we are not uniformly prepared. The legal clarity aspect of it has improved post Common Cause versus Union of India updates. It makes the withholding, withdrawing, and has become more feasible in practice, become little more talked about, and little more accepted even among medical fraternity. And there have been this ISCCM and IAPC joint statements also, and the clear ICU pathways are laid out regarding foregoing life-sustaining treatments. But where we need to be careful is that it is not interpreted as abandonment. It is not abandonment. It is not stopping care. It is still continuing to care for the patient. And the goals of care, again, are need to be clearly defined day after day. And there is an emphasis on totally on communication, ethics, and law integration in this. So I would say ULC is implementation of it is uneven, and there is more urban acceptance, and still medical fraternity also needs to be more aware of this. And I would say the implementation of palliative care early on is still in a very nascent stage, considering intensive care and training, lack of training or awareness. And there is a cultural reluctance in our setup to discuss death openly. And the public awareness again is another aspect. So the fear of litigation is also there. So there is no uniform policy implementation. We are legally ready, conceptually aligned, but operationally we are still inconsistent. For the second question, I would say yes, it would definitely help to have a uniform documentation. Currently, each hospital has its own forms, and documentation quality also varies. Whereas if you have a uniform documentation, it will protect clinicians, and it will also prevent fear-based over treatments. So I think the goals of care, documentation, family understanding, and what they understand about the clinical condition, the outcome, and what are the goals of care, whether we are all on the same page, the documentation of it has to be there. But a uniform documentation will go a long way in bringing it into practice. Yeah.
So, Manisha, we all know about the recent legal developments and they continue to shape our practice. But how has the Hearst Rana versus Union of India judgment influenced the practical implementation of end-of-life care and advanced directives in India? So, has the judiciary also shifted towards the patient rights, as you all spoke about, centered approach, and reduce the procedural ambiguity for clinicians at the bedside?
I think this is a big milestone. It has made absolutely clear that it is legally valid to withdraw life support. Okay. Now, clinically assisted nutrition hydration one at one extreme end of the spectrum where we have misgivings about withdrawal. Okay. We've
Yes.
always had misgivings about withdrawing ventilator and all that. It's taken us 2 decades to overcome that. Now, willfully removing artificial feeding requires more legal clarity. Okay, even in countries with well-developed systems of withdrawal withholding, clinically assisted nutrition hydration has a special place. Okay, and many people had to go to the court to accomplish that. Now, so this is a big step in clarifying that CANH is also medical treatment. Okay, otherwise, the earlier High Court judgment thought it was not a medical treatment; it was essential,
Right.
mandatory to feed everybody. Okay, so they thought removing feeding would amount to active euthanasia, which is of course not well informed. Okay, it's not a well informed judgment. However, that was overturned by this current Supreme Court judgment, which clearly said, in this current context of PVS, the CANH is the life support. You know, the people with PVS don't remain on ventilators and all that. Their brainstem is working. So this is a very important development. This also puts everybody at ease that withdrawal decisions will not be mistaken or conflated with active euthanasia. Okay. Unfortunately, they continue to use the word passive euthanasia, although the judgment mentions that this is an obsolete word. Okay. They used the word, but they called it an obsolete word. It should be replaced by withdrawal and withholding. So I think the tide is turning surely in the favor of modern terminology and modern medical practice. Now today, Harish Rana was liberated from his trap in the somatic existence trap of 12 years, and this is a very humane development. So it showed that at the court level, humanity prevailed, not just legality bereft of the human side. It is the misgiving that we may be doing active euthanasia by removing artificial feeding. That myth has been busted, and it is also made very clear that the patient, through the family, has the right to refuse any form of life support. Okay, any form of life, anything that sustains life in that particular person, they have the right. So they respected the parent's decision for having the feeding tube removed or having nutrition removed. And all the misgivings the patient may suffer in the process is also not scientifically correct. This we know as physicians that in a PVS patient, it's very unlikely the patient would feel hunger, okay, or pangs of anything like that, or have any experience of pain. Okay, it is not at all obvious or clear. In fact, most of the write-up on this issue argues against it. That is why it is ethically and morally and scientifically justified. And I'm very glad that this is. And then another point about this case is it's the implementation of the 2018 judgment for the first time, a court-directed implementation. We are having a lot of implementation difficulties because the system is not in place for having the DHO appointee in the secondary board. We in our place, we follow the Karnataka government, uh, alternative that you use the brain death committee member as member of the secondary board. And you can only follow the guidelines to the extent it is possible. If the structure is not put in place by the state government, you can't use that to deny the patient the right to refuse treatment. So in principle, we could follow. To the letter, we may not follow unless the government's machinery is in place. So this we must take the lead. We must champion the cause of appropriate care in our ICUs, and we must not take the procedural obstacles as an alibi. Wherever the secondary board cannot be formed as per the Supreme Court's directives because of lack of infrastructures put in place by the state government, it is okay. You do without it. You have two boards. The principle is to have multiple physicians and have an oversight panel. That's all, and that's what we did. And then when the Karnataka government, circular came about, we integrated that into our SOP. So this is all doable, and we are very comfortable. And there is everybody involved is very comfortable. They are not arguing again what is it legal and things like that. So gradually we have learned that the ethical way is the legal way. Okay, the professional way is the right way.
Okay.
We cannot use impossible legal procedures to hide behind our inadequacies in this aspect.
Understood, sir. So eventually, we are moving towards a more patient-centric approach, and they've understood the importance of the liberation and not continuing just because the initial judgment, what you spoke about, they thought of nutrition as an essential. Now they're taken it as a life support, and it's come in our favor. And this is the reason why today Rana was liberated from the somatic trap what he spoke of. So as we move ahead and look into the future directions, Dr. Praveen, this is the last question. So, looking ahead, the real question is, are we prepared for what's next? So, are we ready to integrate palliative care into routine ICU practice as it's been practiced in the few hospitals as well? And should end of life care training be mandatory for the intensives, and how can we improve the public awareness about living wills?
See, as everybody's mentioning, we are in very initial phases of, integrating palliative care into routine practice. And as Dr. Gursahani was mentioning, if we have a palliative care physician on board, that solves, a lot of problems. It becomes easy. And definitely, I would be a bit honest about it, but I have seen many senior clinicians not comfortable talking about, end of life care. Somehow, it has to be integrated from very early training phases. We have to be uh, taught about the communication, because I think about my training, there was no specific training on how communication should be done. We all have learned over the years by doing, practice and observing our seniors like Mani sir and all this. We have learned over years that this is how it should
Parveen, we lost you.
be done. So it should
We lost you.
be
If you could put off your video, I think maybe it's a network issue. Somehow we can't hear. Gursani sir, you want to
No.
pick this up? Yeah.
Yeah. I absolutely think end of life care training is
Am I
mandatory for
audible?
intensivists.
Now, yes.
Yeah, okay. Let her.
Yes. Parveen, you want to say? Continue.
So that is what I was saying. Yeah, that is what I was saying, that it is very, very essential for intensivists to be trained in this. And many senior people still, they are also not comfortable initiating this discussion. So, and this recent the judgment which has come, I think now people are at least talking about it, trying to understand what exactly is, and it will solve, the fear, the unsaid legal fear, that will also put some ease into the minds of clinicians that it is doable if done in a proper manner.
Sir? Gursani sir.
When I trained in medicine, uh, this was 1980s, early 1980s. Nephrology was just about beginning to be established. So you referred patients to nephrology only when the creatinine crossed 10 because they would go on dialysis and they would die. So what was the point, right? And then, of course, now we refer when it is 1.4, creat of 1.4. The same thing happened when I was doing my DM in neurology. There was no intensive care. We had two birds respirators in the side room in our ward. And we used to do manage GBS and whatever it was there. Now, can you not? Can you work without an ICU setup in a big hospital? No. I'm saying that again, the same,
No.
again, in that sense, palliative care is in some ways an intersectional interdisciplinary specialty like intensive care is. And it is up to intensivists to support the uptake of palliative care.
Absolutely.
The way you were supported. I mean, there were enough people who said, no, we need a specialist intensivist. And again, we must all work towards setting up palliative care.
No doubt.
Learning yourself is absolutely good, but it's a specialty that needs to be supported.
Yes. Got it. So we're just about to close. Kalavathy, quick word. You want to come in? Unmute.
There is a misconception that palliative care is end of
Life care.
terminal care. But
No.
what needs to be made aware is that it is a comfort care and compassionate care, and it is a patient-centric care.
Yes, very precisely. So, thank you for such insightful perspective. If there's one takeaway, what we got from this is end of life care is not about stopping care; it's about choosing the right care. And as a clinician, our role is to just not to prolong life, but to ensure that life until its very last moment is meaningful and human. And this is what we all spoke. So let's move forward with greater clarity, confidence, and most importantly, as we spoke about compassion. So sincerely would like to thank all of our esteemed panelists for sharing their wisdom and experience. We all have learned from you all throughout this years, and again, this was a learning experience. And thank you to all the participants for for being part of this dialogue. And because conversation like these are what truly transform care. And have a wonderful evening to all of you. Thank you very much. Thank you, sir.
Thank you, Bharat, for bringing us
Thank you so
together on this
much.
Thank you, sir.
platform.
Thanks for
Thank you.
accepting my.